Hi, my name's Jacqueline. I'm a registered respiratory therapist and neonatal pediatric specialist, and I'm also the lead pulmonary educator for Aventa. In this module, we're going to be going through the ventilator unit technology and equipment. So our goals of this module are going to be understanding indications, benefits, and contraindications of respiratory devices, including mechanical ventilation, invasive and non-invasive, humidified high flow therapy or high velocity nasal insufflation, mechanical in-exsufflation, high frequency chest wall oscillation, and intrapulmonary percussive ventilation. So, is your patient ready to begin weaning trials and utilizing this equipment? Some of the things that we're going to be looking at are adequate cough, sedation has been stopped successfully, underlying cause of respiratory failure has been resolved, the rapid shallow breathing index or RSBI is less than 105, their PEEP is less than 8, they're managing their secretions, they're hemodynamically stable without pressors, and their FiO2 is less than 50%. So we need to make sure first that they have an adequate cough. Are they able to manage their secretions? So if they are unable to protect their airway and have that productive cough, it may, even if it may not necessarily determine that they can't be weaned, it'll at least let us know what challenges that we may have in the future and what kind of equipment that the patient may need to make sure that they continue to be successful. Of course, we want to make sure that their sedation has been stopped successfully because we want to make sure that our patients are taking the best effort with their spontaneous breaths. If they're still under sedation and they're lethargic, they're less likely to be successful because they don't have that same drive. We want to make sure that the underlying cause of respiratory failure has been resolved, specifically with acute respiratory failure. Of course, if their issue is still going on and they're not on track for it to be resolved, then it's likely that they're not going to be successful during weaning. The rapid shallow breathing index, and this is more so for an acute care setting. So remember that this is used with the respiratory rate and the tidal volume to see how each breath is compared with the number of breaths, how deep it is and how fast they are and how shallow it is. Our PEEP should be less than 8 because we want to make sure that they're not undergoing any atelectasis or being at risk for oxygenation issues. Again, we want to make sure that we're managing their secretions, whether the patient is able to manage their secretions themselves or we have something in place to make sure that their secretions are managed. We want to make sure that they're hemodynamically stable without the use of pressures. So weaning trials can be very stressful and they can have some underlying issues, and so we want to make sure that their heart is working well to be able to support them during this process of weaning. We also want to try to get their FiO2 at less than 50%. Anything higher is a large concentration of oxygen, and they really need to have those extra steps taken to bring their FiO2 down or figure out what we need to do to try to bring their FiO2 to a lower level before we really work towards weaning them or liberating them. So now going through the parameters of weaning. Our targeted tidal volume setting is 5 to 7 milliliters per kilogram of ideal body weight. To calculate ideal body weight, males their ideal body weight is equal to 50 kilograms plus 2.3 kilos for each inch over 5 feet. For females, their ideal body weight is 45.5 kilograms plus 2.3 kilos for each inch over 5 feet. The pressure maximum and pressure minimum settings should be between 20 to 30 centimeters of water. Titration of their PEEP setting with the goal of reaching optimal PEEP to maximize oxygenation with minimal end expiratory atelectasis or overdistension, with monitoring of their SpO2, heart rate, and blood pressure. So when we're looking at their targeted tidal volume, we want to remember that our lungs capacities are really determined mostly on our sex as well as our height. Our weight doesn't necessarily, or it doesn't at all impact the size of our lungs and how much air that they're able to hold. So by calculating the ideal body weight, based off of the height, we can get a better representation of how many milliliters per kilo that they're supposed to be getting. So this should be between 5 to 7 milliliters per kilo of their ideal body weight after you calculate it. So for instance, if you have a 40-year-old female who's 5'3", you would use this calculation of 4.5 kilos plus 2.3 times 3, because she's 3 inches over 5 foot. So we would just multiply 2.3 times 3 and add it to that 45.5 kilos to get the ideal body weight. And then with that ideal body weight, well then I like to multiply it between the 5 and a 7 and the 7 mils per kilo to really determine what range they're successful in. We also want to make sure that their pressure maximum and minimum settings are in that 20 to 30 centimeters of water range, because we want to make sure that we're not causing any barotrauma. The titration of the PEEP setting for reaching optimal PEEP, what this is going to do is it's going to make sure that those alveoli are nice and open even when our patients exhale and those alveoli are prone to shrinking. We don't want them to completely collapse, because that's going to cause issues when they take their next breath. It's going to require more pressure and more time for those alveoli to open back up. So we want their PEEP to be just enough to where those alveoli are staying open so that their oxygenation is in its prime. But at the same time, we have to be mindful that we are adding extra positive pressure to these lungs, which is not a natural way for us to breathe. We're naturally negative pressure breathers. So when we're adding that extra positive pressure, we're also applying extra pressure to our circulatory system, to our heart, which is going to impact the heart rate and the blood pressure. The more pressure we're adding into the lungs, it may squeeze the heart, and it's going to have an impact in the overall circulation. So while the PEEP at, say, 7, they may be satting at 100%, but we need to be mindful of their other vitals as well to make sure that their heart is still functioning and pumping properly, and that they're getting the blood pressure that's in a normal range. So more parameters of weaning includes capnography, the use of end-tidal CO2 monitoring or subcutaneous capnography. It's non-invasive. Normal range is 35 to 45 centimeters of water. Can be used to quickly determine adjustments needed or success of weaning. The awareness of the disease process is crucial, and it's the preferred method of CO2 monitoring. So what these devices do is you have a couple of options depending on if you're using the end-tidal or the subcutaneous. We don't see subcutaneous very often, except maybe in the NICU, but it is an option to have so that you can tell how much CO2 there is. So with your end-tidal CO2, it's going to connect. They have nasal cannulas that you can use They're typically not too accurate because of how patients move, and they tend to be rigid and come out of the nose, so sometimes they're not very accurate. But it's more useful for patients that are mechanically ventilated, or we are weaning tracheostomy patients, because it can be placed directly in line with the circuit or applied directly to the tracheostomy. And what it does is it analyzes the CO2 of the end tidal breath. So as they breathe out, the device is going to analyze how much CO2 is in that breath. So, and then show it on a monitor so that we can see how it changes. With subcutaneous, it's going to be using a light to kind of like an SpO2 monitor or a pulse oximeter that uses that light that refracts off of the blood, and it's able to analyze what the CO2 content is with your subcutaneous capnography. But both of them are non-invasive, so you don't have to worry about any extra sticks. You can leave it on for longer. You can use it to monitor without having to worry about, oh, I have to make this another stick, or oh, I can't get this ABG. It's very, very useful. The ranges for the end tidal are in 35 to 45, just like our ABGs, because this is the exhaled. So that's going to be our normal range as well. And it can be used to quickly determine the adjustments needed or how successfully our patients are weaning. So if we have adjusted their, say, tidal volume, we can see quickly just how well they are still blowing off that CO2, or what the CO2 content is if we're using the subcutaneous. We can see quickly and in real time without having to worry about doing a stick and having to take it to the lab or having to analyze it and worrying about it clotting. We can see it right then and there and see if, okay, so we've reduced their tidal volume by 50 mils. So is their CO2 rising drastically? Are they still in the same range? Or are they breathing faster and they're blowing off more CO2? We can analyze it very quickly. But it is important to be aware of each patient's disease process. For instance, we know that our COPD patients tend to be CO2 retainers. So their baseline CO2 tends to be higher than, say, your average person who may be in for trauma, brain trauma, or something of that nature, because they don't naturally retain that CO2 like COPDers do. And it is the preferred method of CO2 monitoring, as I mentioned before, because it's non-invasive, it's quick, and it's overall just more comfortable for your patients. But another parameter that we can look at is the ABG. Normal ranges are pH is 7.35 to 7.45. CO2 is 35 to 45, bicarb 21 to 28, and our PaO2 is 80 to 110. It's the most accurate way of knowing patients' oxygenation and ventilatory needs. Its overall goal is to keep the pH in normal range with optimal oxygenation, with awareness of the disease process. So while the capnography is the best option for monitoring the CO2, since that's the main thing that we're going to be monitoring during this weaning, along with the SpO2, those two things together, because they're non-invasive, are really optimal when we're looking at weaning. But we also have to recognize how ABGs can be important as well, because it does give us that pH to determine if our patients are compensating or not, if their pH is in normal range, even if their CO2 is too high. And it is more accurate. But now if we're having to take a blood draw and take it to a lab and it has potential for clotting, or you're not as experienced and you're getting this venous admixture, then obviously it's not going to be as accurate. But it does provide more information than, say, your typical end tidal capnography. And again, the overall goal is to keep the pH in normal range with your optimal oxygenation. And going back to this idea with our COPDers, they can have a normal pH even if their CO2 is in, say, the low 50s. So it lets us see, okay, are they compensating? Is their pH still in a normal level to where their tissues aren't going to be impacted? And so that's why it's also important to know, okay, what is their disease process? What is their baseline? And what is the normal for these types of patients? Another option is capillary blood gas. It's less painful and time-consuming. And normal ranges include the pH of 7.35 to 7.45, CO2 of 35 to 45, bicarb of 19 to 25, and your PaO2 of 60 to 80. So say that you have a patient where you have them on the end tidal and you're noticing that it's high and it's staying high, and but they're not showing any distress, they're not really showing any other issues with the rest of their bodies. We're not really wanting an ABG because they may be contracted if they have something like cerebral palsy or they have something else going on. But we want to make sure that they're compensating and their pH is still in a normal range. One of the options that we can do is a capillary blood gas, a little finger poke on the side of the finger, never in the middle, but on the side. And the reason why this works is because, remember, capillaries are where gas exchange occurs to your tissues. So it still has some oxygen content to it. It's not as high, but we're not really looking for the oxygen, the PaO2, with a capillary blood gas. We're looking at this CO2 because it's starting to have that gas exchange. It's starting to pick up more CO2 and it's also dropping it off. So we can still see that CO2 range as well as get the pH, and it's going to be the same pH range that we're looking for as our ABG. So it's faster, it's not as painful for the patients. We can also, there's technology to where you can analyze it at the bedside as well. And there's also the venous blood gas. It could be drawn with other blood cultures. In our normal ranges, they're going to be different. pH is going to be 7.32 to 7.42, carbon dioxide of 38 to 42, bicarb of 19 to 25, and our PaO2 is 24 to 48. So obviously this is the carbon dioxide rich blood that we can analyze and see how high it is. So as long as we keep in mind what a normal CO2 range is going to be for our venous blood and how it's different for our pH, if your nurse is already gathering some blood, it's an option to go ahead and take a little bit of that and have it analyzed to see what the pH and the CO2 in your bicarb is. Your PaO2, of course, is going to be very low because it's already dropped off the majority of the oxygen. But it is an option to use to analyze your pH and CO2. Moving into our ventilators as it pertains to weaning. So we have our average volume assured pressure support auto titrating EPAP, which is non-invasive, pressure support ventilation, invasive and non-invasive, and synchronized intermittent mandatory ventilation. So first up is our AVAPs. Benefits include combines volume and pressure controlled ventilation, the ability to set a range for IPAP and auto-adjusting EPAP. Tidal volume varies with each breath. This mode helps prevent patient and ventilator desynchrony, and it's utilized for non-invasive. Indications include stable hypercapnic COPD patients, acute hypercapnic respiratory failure, a COPD exacerbation, ongoing respiratory support after liberation from mechanical ventilation. But some contraindications include the inability to protect the airway, vomiting, they're hemodynamically unstable, or they have facial trauma. So the good thing about AVAPs is that it does combine the volume and the pressure for each breath. So typically we'll set a range of the volume. We have a target volume and then the pressure is going to vary. And so we can really make sure that the patient is getting just enough for what they need. And as their compliances change, the ventilator is going to change with them as well. But at the same time, we're giving the pressure a targeted range to reach that volume. So unlike, say, our SIMV on volume control, where the pressure can go wherever it wants in order to achieve that volume, we can set a range to make sure that they're getting the volume they need without putting them at risk for barotrauma. The tidal volume is going to vary with each breath. Again, because we have a range for the IPAP and the EPAP, we have a range for the pressures. So of course the tidal volume is going to vary each time your patient takes a breath. But because there is some wiggle room and there's some variability, it helps prevent the patient and ventilator desynchrony. You're going to be less likely to see your patients trying to fight against the ventilator with their breathing because they have wiggle room. They have a range that they can sit in. They don't have to have so high of a tidal volume. They don't have to achieve it, even if their lungs don't want to do that or your patient doesn't want to do that. You have a wider range. But it's also important to realize that this is specifically for our non-invasive patients. So for the indications, anything that's hypercapnic, whether they be a stable hypercapnic COPD patients, someone who is in acute hypercapnic respiratory failure, COPD exacerbations, they tend to be having a higher hypercapnia. And the reason for this and why it can be indicated is because of that variability. It lets the patient take a little bit more charge of trying to blow out that CO2, and they're able to blow it out a little bit easier because of that range. And it's also useful for our ongoing respiratory support after they're liberated from mechanical ventilation. So if you have a patient who is, they've just been extubated or they've just been decannulated, but they are getting off of that mechanical ventilation, but they still need some extra support, then we can apply the AVAPs non-invasively so that they can still have that range. They're still using their respiratory muscles to get them where they need to go and to strengthen them, but at the same time, they're still getting that extra support as they're being liberated. But it's important to know that because this is a non-invasive mode, that your typical contraindications with non-invasive also apply to your AVAPs. So for instance, your facial trauma. You can't have a mask on if you have a patient who's had some trauma on their face, broken jaws, they've just had facial surgery. It's just not gonna work. If they're vomiting, if they vomit into the mask and then that pressure is pushing it back in, you have a higher risk of aspiration and aspiration-associated pneumonia. Again, we want to make sure that they're hemodynamically stable when we're applying it. If they're not hemodynamically stable, it's a contraindication because of that extra pressure that we're applying. And the inability to protect their airway. If they're not able to manage their secretions or have a good cough, it's a contraindication again because this is a non-invasive mode and we don't have a way to really protect the airway. Moving on to pressure support ventilation. So benefits and indications. They're patient-triggered breaths. It's a decreased work of breathing. It allows for spontaneous breathing trials to assess for liberation in invasively ventilated patients. It's supportive ventilation to patients requiring non-invasive ventilation. Contraindications include decreased respiratory drive, they're hemodynamically unstable, and patients receiving sedation. Our pressure-supported ventilation, these are going to be all spontaneous breaths. Your patient is triggering all the breaths. But what it does is it adds a little bit more oomph with each breath, with the idea of, okay, if they have a tracheostomy or an ET tube, they're having to breathe through a smaller diameter, and so it's naturally going to increase their work of breathing. It's not the patient's fault, or it's not the patient's body's fault, it's just what they are having to work with. So the pressure support ventilation just adds a little bit of oomph so that they can breathe through that smaller diameter and decrease that work of breathing to overcome that resistance from having a smaller airway than their natural airway. Now we can use it for our invasive patient as well as our non-invasive patients. With non-invasive, it's just going to be more supportive. They're still spontaneously breathing. They're not going to typically be having a rate. They're not going to be having a targeted tidal volume. It's just going to be a little bit of extra support. And then for our invasive patients, again, it's going to allow them to spontaneously breathe, see how well they're spontaneously breathing to determine if they are ready for liberation. Contraindications, again, this is a spontaneously breathing mode. So if they have a decreased respiratory drive, such as when they're receiving sedation, they're likely not going to do well on the pressure-supported ventilation because they're not taking those spontaneous breaths, or they're not taking enough of those spontaneous breaths. And just like with all of our ventilation, if they're hemodynamically unstable, they're likely unable to wean. Now, it is also important to note that pressure support can be utilized in conjunction with other modes of ventilation, but in this case, we're more so looking at pressure support ventilation on its own to help our patients liberate. Moving into SIMV. So SIMV can be volume controlled or pressure controlled. Our volume control delivers a set tidal volume with a variable peak inspiratory pressure. Pressure control delivers a set peak inspiratory pressure with a variable tidal volume. The rate is ensured, but allows for spontaneous breathing. Spontaneous breaths are supported to achieve set values. Without spontaneous breaths, it still provides full support. It can be utilized along with pressure support. It supports spontaneous breaths to decrease the work of breathing, but it's also found to be the most ineffective method of weaning.
For both recordings, the air was supplied at 25 liters per minute and 38 degrees Celsius from the humidifier. For simplicity, unidirectional airflow has been used in all the demonstrations. As we mentioned earlier, heat and water vapor are normally partially recovered during expiration. As the clip starts, the right trachea has been exposed to a constant airflow at lower humidity for 15 minutes. Although you can see tiny beating cilia flickering in the background of both clips at this stage, debris in the mucus of the right clip are stationary. Mucus transport is essentially stopped. The dark spots moving quickly across the left clip now show debris being cleared by effective mucociliary transport. After only an hour at the lower humidity, the mucus layer at the right has completely dried out.
So with SIMV, we have options in what we want to set for our patients, what goals we're setting for our patient, as well as the ventilator. If we're doing volume control, we're going to set the tidal volume ideally in that ideal body weight range for their tidal volumes. And so the ventilator is going to make sure that no matter what, that tidal volume is going to be delivered, and the pressures are going to adjust to ensure that that tidal volume is going to be achieved. Vice versa, with pressure control, we're going to set the inspiratory pressure, and then the tidal volume is going to vary dependent on what that pressure is doing, what that pressure is achieving. Now, with pressure control SIMV, it is very beneficial because it's going to reduce the risk of barotrauma, because we don't have to constantly be monitoring that inspiratory pressure, and we're not going to have to worry about it going in too high of a range to the point where they're at risk for barotrauma. The pressure control SIMV is especially beneficial for patients who are having very rigid lungs, to where they're not going to inflate as much, and if you keep on pumping that pressure in, it can cause trauma to the lungs. Another thing with the SIMV is that the rate is ensured. We're going to set a respiratory rate. We're going to tell the ventilator, hey, no matter what, this is the rate that we want this patient to achieve to make sure that they're blowing off their CO2, that they're ventilating, that they're oxygenating. But if our patients are spontaneously breathing, they can breathe more than that rate. The ventilator isn't going to block them out from taking extra breaths. But if the patient starts to stop spontaneously breathing, say they have something like central sleep apnea, or we're having to sedate them every once in a while, the ventilator is still going to be providing breaths. It's going to provide that extra support. Or if our patient is spontaneously breathing, but they're not taking large enough breaths to reach the goal that we set, whether it be the tidal volume or the pressures, then the ventilator will give them a boost to make sure that they're reaching that tidal volume, or that they're reaching that pressure. And pressure support can be utilized along with it, so it's going to add that extra oomph with this spontaneous breaths. So with each spontaneous breath, that pressure support will kick in, make sure that they're overcoming that resistance, and so that they can spontaneously achieve those settings without having to worry about the work of breathing. However, because of how much support SIMV does provide, it's typically not the most effective method of weaning. It's a good stepping stone because it starts to allow our patients to be taking spontaneous breaths, they're getting off sedation, we can start seeing, okay, are they breathing over, what is it kind of looking like, how often is the ventilator having to take control. But going from SIMV straight to liberation is typically not very effective because of how much support SIMV is still providing. Now, moving into the opportunities for non-invasive in the weaning process. It can aid with decannulation, with capping, with non-invasive, the prevention of ventilator-associated pneumonia. There's no invasive access. It's a reduction of barotrauma risk. And precautions are skin breakdown and monitoring of oral secretions. So with non-invasive, it can aid with decannulation. If you have a tracheostomy patient and we're wanting to try to decannulate them. They're doing really well, but every once in a while they may tire out, or at night they are showing signs of apnea and they're just needing a little extra support. Not full invasive support. We want to see if we can still try to liberate them to something else, and we're able to decannulate them and provide them with another form of support. So when we cap our patients, which is something that we should be doing if we're moving towards decannulation anyway, once they're capped, because that airway is occluded and they're not going to be breathing out of the tracheostomy, no air is going to be coming in through there, no air is going to be coming out from there. We can apply the non-invasive while they're capped to see how well they do with the non-invasive when they get decannulated and they no longer have that opening. It's a good trial run to kind of see if we're able to support them non-invasively once they don't have that tracheostomy tube anymore. It's also a great way to prevent ventilator-associated pneumonia. So because we don't have a direct access to our bodies, like say with our tracheostomy tubes, there's not direct access straight into the airway and straight into the bodies. Or with our ET tubes, we don't have direct access straight from the outside of the tube straight into the body. So it's not as easily attained to have ventilator-associated pneumonia because we don't have that access. And there's also a reduction of barotrauma risk. Typically our pressures are going to be lower and it's not directly applied to the airway. And so that pressure isn't going to be as severe as with our invasively ventilated patients. So there's less risk for that pressure to harm their lungs and their airways. Some precautions to be aware of with non-invasive is that there can be skin breakdown. No matter what type of mask you use, whether it be a full face mask or a nasal mask, it can cause some skin breakdown, especially if they're on it continuously. So we want to make sure that, say, every 4 hours, removing the mask, seeing if there's any skin breakdown, and also applying barrier devices where it is. Another good idea is to rotate through the types of masks that our patients are wearing, especially if they're on it continuously. If they're typically on the full face mask, every few hours switch them to a nasal mask. Give this area rest, let it breathe a little bit, reduce that chance of skin breakdown. Then after a couple hours of using the nasal mask, switch them back to the full face mask and just rotate them through to reduce that chance of skin breakdown. All the while, again, making sure that we're applying some sort of skin barrier device. And we also want to make sure that we're monitoring oral secretions. This is especially important for if we're having a full face mask in place. The reason for this is if we have a patient who is having a lot of oral secretions, they're really drooly. Say, for instance, I know for me, a lot of my cerebral palsy patients in the past have a large amount of oral secretions, but they're on non-invasive. And that mask fills up so quickly with these secretions, and they're breathing those secretions in and it's bubbling and they're starting to get red around here because of that extra moisture underneath the mask. So it's really important to have that yonker present, making sure that we're able to manage their oral secretions, and if it's just too much, seeing what kind of pharmacological options that we have to reduce those oral secretions and dry them out a little bit more so that we can continue with the non-invasive. Now, going into the specific types of ventilators, the value of using lightweight portable mechanical ventilators. Portable ventilators allow for easier ambulation, participation in rehabilitative services, and participation in recreational activities. It aids in prevention of respiratory infection, gives patient a sense of self, it improves motivation for weaning and liberation. Benefits of multifunction ventilators It's beneficial of improved infection control. It's a reduction of circuit breaks, which helps prevent VAP and other respiratory infections. There's multiple therapies within a single circuit, and it's increased compliance due to shorter therapy times. So when we're talking about the type of ventilator that we're using for our weaning patients, or even our chronic patients that are on the ventilator, they're chronically on the ventilator, by using a ventilator that is lightweight and it has a battery pack and they can move with it, it's going to allow them to get up and get stronger, move around. It's going to allow them participate in physical therapy or occupational therapy, in bingo, and anything that they want to do that's going to help them feel better about themselves and help them get their body stronger. And by them moving around more, able to get up, walk around, take a walk around the yard or whatnot, it's going to aid in the prevention of respiratory infection. The more that we move, the more we're jostling those secretions up in our lungs and our airways, so that then they can be coughed up. And so those secretions aren't staying and sitting in one place. Say if we have a patient that's in bed that can't move, isn't getting out of bed, they're more likely to get those respiratory infections because of how those secretions are sitting there. And it's also going to give them the patient a sense of self. They're able to have a little bit more independence because they're able to get out of bed and do what they'd like to do. And because they're able to get up and do what they enjoy, it's going to motivate them to wean and liberate. If they're thinking to themselves, man, I can get up and walk around with this ventilator, I'm doing more things that I enjoy. What more could I do if I work towards getting this ventilator completely gone? So it's a great motivator as well. There are some multifunction ventilators, and these are ventilators that provide the mechanical ventilation as well as also provides various therapies for secretion management or nebulization. And it's beneficial because it's going to improve infection control. The more times that we break the patient's ventilator circuit to apply, say, a nebulizer, a T-piece nebulizer, or we're breaking it to place them on something like Metaneb or IPV rather, there's an increased chance of them getting VAP because we've broken the circuit. There's the opportunity for all those microbes to get into that circuit and into our patient. And the good thing about it is that we have the multiple therapies within a single circuit. So we're not having to break it. We're not having to take the time to disconnect, get what we need to put into it back in, and then reconnect it, make sure our patient is oxygenating, making sure that we've got the next treatments available, making sure that our ventilator's still set up, and while we're doing therapies, it's screaming at us with alarms. It allows us just to have that single circuit just to plug it in and let it roll. And it's going to increase the compliance of our patients due to shorter therapy times. It's going to allow them to stay where they are and not have to worry about all the steps that they have to take in order to do their therapies and get them to where they need to go. And it's also assisting your care team in a facility because they're not having to take as much time to do all these additional steps to give the patients the therapies that they need. Humidified high flow therapy or high velocity nasal insufflation. So clinical benefits of humidified high flow therapy: it decreases risk of infection, improves secretion management, VAP is avoided. There's benefits of 100% relative humidity with the mobilization of secretions and prevention of mucus plugging. Interfaces for the devices include nasal cannula and trach collar, and direct connect is available for some systems. There's benefits to traditional cool mist aerosol. including secretion management for patients with temperature regulation complications. So there is going to be another module on the use of humidified high flow and high velocity nasal insufflation, and I highly encourage you to watch that module to get more in depth with this. But very briefly, the good thing about high flow is that it's going to decrease the risk of infection because it's going to improve secretion management. That extra humidification is going to loosen those secretions so that they can be mobilized and coughed up so that we're not risking that. There's also benefits in the 100% relative humidity, which is what we're trying to achieve with the humidified high flow, and its prevention of mucus plugging by keeping the airways hydrated and those secretion mobilizing. Even if our patients aren't necessarily coughing, they're still being mobilized up the airway. There's multiple interfaces for the devices. You have your nasal cannulas and you have a trach collar, so it can be used for both your non-invasive as well as your invasive patients or trach patients. And then we have the direct connect, which works very well, and it's available for some systems to where it directly connects to the trach and you don't have to worry about as much disconnection or the trach collar moving. There's also the option of traditional cool mist aerosol for secretion management, especially if we have patients who have issues with their temperature regulation, and applying that extra heat can cause some issues for them. It can spike a fever or lead to seizures. So there is a benefit to that cool mist to still keep those secretions hydrated. However, there is a higher risk of your patients contracting that. Mechanical inexsufflation. It's also known as cough assist. It simulates and or stimulates a cough. It reduces the need for tracheal suctioning, provides a positive and negative pressure and a break between coughs. The positive pressure or insufflation opens and hyperinflates. There's a maximum pressure of 35 to 40 centimeters of water. It's adjusted based off the member's ventilatory pressures and stature. The negative pressure or the exsufflation pulls and mobilizes. It should be 5 centimeters of water higher than the positive pressure and allows for secretions to be pulled out of the main bronchi for removal. And then there's a break where no pressure is added and lungs return to their normal compliance. It can be used following oscillation therapy and can incorporate oscillation directly, simultaneously via the cough assist. Breaking down this mechanical inexsufflation or cough assist. Simply put, we have 3 pressures. We have our positive pressure, that 35 to 40, depending on the age, the stature, what their ventilatory needs are, what their normal PIPs are. What that's going to do is going to apply that pressure and it's going to hyperinflate the lungs, kind of like Easy PAP does or our incentive spirometry. It's going to hyperinflate it. And as they're hyperinflating, it's going to help break loose those secretions. And then after that, we're going to have the negative pressure. We're negative pressure breathers. So what this means is that it's going to be pulling that pressure back out. So it puts it in and then it's going to pull it out. And this is the cough of the cough assist. This is what is going to bring it all the way out so that it can either stimulate the cough for the patient or it's going to make it easier for us to suction. Now the settings of this is really important. We want the negative pressure to be a higher number than our positive pressure. And the reason for this is because if we have 35 positive and negative 35 for our negative, those secretions aren't really going to be going anywhere. They're going to be staying in the same spot. The positive pressure is going to push it down with that pressure, and then if it's the same pressure, it's going to end up exactly where it was before, and it's going to be in the same spot, and we're not really going to be achieving anything. One of the things to note with cough assist is that it can be uncomfortable for a lot of patients because it's literally pulling the breath out of them with that negative pressure. It's important that you're explaining it to the caregiver and the patient what it's going to feel like, what it's for, what to expect. When we're doing cough assist, we like to make sure to do about 5 breaths per round and 3 rounds. This can be adjusted depending on our patient's secretions and what they're needing. If they have an infection, they may need it more often. But that's typically our goal of what we like to do and what we see most of the secretions coming up effectively without having to worry about the patient having compensation or decompensation with their vitals, which is another important point, is watching the vitals continuously and making sure that we're watching the SpO2 and the heart rate and making sure that they are not dropping in their SpO2, that they're not desatting. So it can be utilized for multiple disease processes, neuromuscular disease and spinal cord injuries, to reduce non-existent cough, lack of mobilization, reducing secretion management, and prevents atelectasis. For weaning and chronic patients, reduces infection risk with secretion mobilization. It's a mode of secretion management to increase likelihood of weaning and can be used invasively and non-invasively. And contraindications include untreated pneumothorax, increased intracranial pressures, and vomiting. It's very useful for our patients who are not able to cough effectively. If our patients have a strong cough to where they can mobilize those secretions on their own, there's really no indication for the cough assist because they are coughing on their own. They don't need any assistance. But now if we have a patient who has a very weak cough, or they don't have any cough whatsoever, that can be an indication that we should try to incorporate the cough assist to help mobilize the secretion mobilization because they're not doing it on their own. And it's also going to prevent atelectasis, especially if we have our patients who are non-ambulatory because they're not able to expand their lungs as effectively with normal mobility. If they're not able to get up and move around, they're not going to have the same lung expansion. And that positive pressure of the cough assist is going to assist with preventing the atelectasis. It does decrease the risk of infection with secretion mobilization. Again, those secretions aren't staying where they were before and they're not festering, they're getting pulled out. And it can be used invasively and non-invasively. You can connect it directly to the airway if they have a tracheostomy or they have an ET tube, or there's the option of a mask that you can place on the patient. Contraindications, if they have a pneumothorax that hasn't resolved yet, that extra pressure is going to worsen it. Vomiting, if we're adding extra pressure into their stomach, because especially if they have a mask and it's being pumped into their stomach, there's an increased risk of vomiting and aspiration. High frequency chest wall oscillation was commonly used in vest therapies. Oscillation devices and weaning approaches assist with secretion management to allow for easier weaning. It's beneficial for non-ambulatory weaning patients. The oscillation for secretion management can be beneficial for invasive, non-invasive, and any other patients. Can adjust the amplitude and the frequency. It breaks down secretions in the lower airways and mobilizes to the main airways to be expectorated or suctioned to reduce mucus plugs, and can be used prior to mechanical inexsufflation. The oscillation breaks it up and the cough assist brings it up. So what the HFCWO, or the vest therapy as it's most commonly known, does is that it provides all of these oscillations to the chest wall from the outside to break those secretions loose, especially if you have patients that have really thick secretions, say our cystic fibrosis patients, our bronchiectasis patients, as well as many others it can be useful for. It's going to break it up with those oscillations so that they can be coughed up or they can be suctioned out. And the good thing about the vest is that you can adjust the amplitude, which is how hard it's shaking the patient, and the frequency, which is how fast. So if we have a patient that's smaller and they're growing, we can adjust it based off of what works best for the patient. It's also really useful prior to our cough assist, because if we have a patient that isn't able to cough it up after it's shaken loose, it'll shake it up, and then the cough assist is going to take advantage of all of those extra secretions that have broken loose, and it's going to bring it up, and it's going to mobilize those secretions and prevent infection. Some contraindications: rib fractures, recent head or neck injury, hemoptysis, pulmonary embolism. You want to assess the port under the vest, and hemodynamically unstable. So with our vest therapies, of course, there is oscillations applied to our to the chest, and so any issues that may be occurring that haven't been resolved with the chest wall, rib fractures, or anything like that that the shaking can impact, that's a contraindication for the vest. If our patients have any sort of ports, such as feeding tubes, anything like that, we want to make sure that we're protecting that port with some sort of padding, such as a diaper, a brief, something like that, that we can put over the port so that when we fasten the vest over, it's not going to be directly hitting the port. Intrapulmonary percussive ventilation, or IPV. It's percussion from the inside. It oscillates directly into the airway. It's invasive or non-invasive, can be more effective than vest therapies. Many devices are multifunctional. They have chest high frequency oscillation for secretion management, continuous positive expiratory pressure or hyperinflation, and it can also provide nebulization. What IPV does, it's kind of like the vest, but from the inside. Those oscillations are going to be applied directly to the airway, whether it be mask, mouthpiece, directly to the trach or ET tube. So those oscillations tend to be more effective than, say, your chest wall therapy. That's not to say that the vest isn't extremely effective, but different patients have different needs. Another good thing about IPV is that while it's also giving these oscillations to the airway, when it has a break, we're having this continuous positive expiratory pressure, which is like that positive pressure with the cough assist to cause that hyperinflation. So it'll hyperinflate and oscillate, hyperinflate and oscillate for optimal secretion management. And while that's going on, we also many devices allow for nebulization at the same time. So you may want to pre-medicate with your albuterol, and then you can instill hypertonic saline, 3%, hypersal, whatever you like to call it, into the IPV nebulization cup for it to be applied while they're also getting these therapies. And finally, with all of these, we also want to make sure that we are watching our alarm systems and our remote monitoring. Utilize advanced alarm systems to record and report all events. Track and trend alarms for resident safety prioritization. Train and educate the staff on the importance of prompt alarm responses. Educate on proper alarm parameters to prevent alarm fatigue from staff. Utilize remote monitoring to provide freedom for out-of-room experiences. Provides additional safety measures to residents who are able to participate in rehabilitative therapies and recreational activities. And it gives residents confidence and motivation to continue progressing. So with any of these therapies, any of these changes in mechanical ventilation, we want to make sure that we have our monitoring and alarm systems at an adequate level. And this is especially important for our weaning patients because every time we make a change, we want to make sure that our patient is doing well with those change. It's not a set it and forget it situation. When you might think that a patient will fly on certain settings after reducing them, they may not. And if we're not tracking and trending the alarms every time they have a desaturation, every time that they have their heart rate spike, we're not really getting a clear picture of what's going on when we're making those changes. It's also important that we educate staff on responding to these alarms, not just figuring that it's one thing or, oh, they're moving around. When they're actively weaning and moving towards liberation, we really need staff to see every time what's going on, every time that the alarm is going off. Alarm fatigue is very real, and so it's really important just so that they know what is going on and keeping them aware of every time their patient's alarm. And another benefit would be to utilize remote monitoring. And what remote monitoring does is it allows the patient to have a monitor system on their body, and then the information is available to the caregivers. So while they're up and moving around and using therapies, they're not directly connected to a big bulky box to where they can't participate in as much because they're having to carry it around, or they have to make sure it's plugged in constantly. And it also allows us to see trends when they are up and moving around and out of the room, seeing how well they do, or seeing, okay, do they need a little extra support during therapies? And now it's time for a knowledge check. Question 1. A 25-year-old post-MVA is a paraplegic and tracheostomy patient who is unable to ambulate. Within 4 days of long-term facility admission, clinicians have noticed that he has been having a strong, juicy sounding cough and is complaining of chest congestion. Physicians are concerned that the patient is at risk for pneumonia. What should be recommended? High-frequency chest wall oscillation. He has a strong cough, however, he's not moving around as much. And so we have to do a little bit more moving for him to break up these secretions. So that's what that oscillation is going to do. It's difficult to clear secretions in the lower airway when you're not moving around and not mobilizing those secretions. So it can be effective in jostling those loose so then he can actually cough it up. We can also incorporate pharmaceuticals in conjunction with our vest therapies, such as our albuterol or hypertonic saline, to help thin them so it's easier to cough them up. If it seems like our vest isn't doing enough, we of course can consider our IPV therapies as well for a little bit more intensive therapy. Number 2. A 40-year-old tracheostomy patient has been on course for decannulation, but appears to require additional support at night, including a respiratory rate. He currently is capped during the day and is utilizing SIMV PC at night. Physicians want to continue to try to decannulate, but are concerned regarding success post-decannulation. What is your recommendation? Cap with a non-invasive. So what we can do is we can cap the patient if they're being capped anyways, or we're moving towards capping. Place the cap and then place them on the non-invasive and see how well they fare with that. See if that's enough support for them, because non-invasive can be obviously applied post-decannulation because it's non-invasive. So just because they're still requiring some support doesn't mean that we still can't make move towards post-decannulation. And it can also help us determine the settings needed post-decannulation. Number 3, a 62-year-old invasively ventilated patient is on the pathway to be liberated, but first requires further weaning of ventilator settings. What is the best method of monitoring success? First, we want to monitor the vitals. Of course, SpO2, heart rate, blood pressure. These are all significant. Also, we want the capnography, the non-invasive, such as our end-tidal CO2, which is non-invasively going to be monitoring the CO2, and it's going to allow us to be able to see the trends and see if they're still ventilating well as they're weaning and as these changes are being made. And we also want to make sure that the staff are involved, making sure that they're responding to alarms, both if it's vitals alarms, such as with the pulse ox, the heart rate, blood pressure, as well as any alarms on the ventilator as they're moving towards getting them off of the ventilator. And we also want to make sure that our staff is involved in documentation for trends so that we can see what worked, what didn't work, how long did it take for this to work, so that in the future they can be successful. Number 4, a 22-year-old cerebral palsy patient that baseline utilizes binasal cannula at 2.5 liters typically completes cough assist TID for secretion management due to a weak cough. The patient's nurse noted to you that the patient has been vomiting throughout the night and is concerned about aspiration. How should you proceed during your rounds? Do not complete the cough assist therapy until the vomiting has been resolved. Remember that vomiting is a contraindication for the cough assist, regardless if it's non-invasive or invasive, because we're putting that extra pressure into the body and it can lead to an increase in vomiting, and which can then lead to aspiration, and especially with cerebral palsy patients who have more difficulty managing secretions anyways and are at higher risk of aspiration pneumonia, it's especially important not to risk inducing vomiting. Make sure that you're utilizing your Yonker for suctioning until vomiting has been resolved. We also don't want to deep suction because that can again cause an increase in vomiting. So using our rigid suction to get the oral secretions and making sure that anything that is coming up is being taken care of. And we also want to ensure that the patient is adequately hydrated. One, because they are vomiting, and so they're going to be losing fluid, and it can cause issues to the cells and the tissues. But also, the more hydrated they are, the more likely it is that we're going to be able to manage their secretions more appropriately once the vomiting has been resolved. Number 5, the mother of a 30-year-old traumatic brain injury patient with a tracheostomy and is mechanically ventilated is concerned about the amount of equipment that will have to be in the home for secretion management, including nebulizer, vest, and cough assist. She's also wary about the use of cough assist with her daughter as it appears to agitate her. The mother wants to ensure that her daughter gets the therapies that her daughter needs, but also wants to try to streamline therapies while also keeping her daughter comfortable. The patient's mother asks you what the best option may be. IPV. It can provide oscillation, CPEP, and nebulized therapies. So it's going to apply our vest and part of our cough assist in one therapy. And it can also provide the nebulization. There's typically less discomfort with the cough than the cough assist, while it's still preventing the atelectasis, because we're not having that extra negative pressure that pulls out the breath like the cough assist does, but we're still getting the impact of the hyperinflation to prevent the atelectasis. You will want to discuss that a nebulizer may still be required depending on the device. Some devices allow for an independent nebulized setting to where you can still hook them up to the device and it just be a nebulized treatment without having to use the other attributes, the oscillation or the CPEP. But you may still need an additional nebulizer for travel or just for quick treatments for exacerbations. And you also want to discuss with the care team to begin the therapy before discharging to monitor vitals and adverse effects. We want to make sure that if we go along with the IPV, that the patient is stable, that she's not desaturating, that she's not vomiting, that she appears comfortable, and also making sure that the family is comfortable with the device as well. I want to thank you for joining me in this module for the ventilator unit technology and equipment. Again, my name is Jacqueline, and I appreciate you joining me.